Good morning, I'm Dhyan. I'm from Team Neurat, and today we wanted to give you some intuition of how our dementia screening tool is working. We are really passionate to work on the dementia screening tool. Dementia has been something very important to all of us since a very long time, so we are grateful. And we today want to show you a little bit of what our tool is doing and how it is different from the plethora of tools already available
Alright,
online.
now as promised, I will quickly gloss over the entirety of a presentation, focusing primarily on the working of our model, so you get this intuition of how it is that our model is actually functioning. Now, I want to quickly first elucidate on what our model actually is. Our model is a screening model, yes, which is what was required from us, but our model is also prediction model. So what we essentially are is a we use a Cox medical grade Cox regression tool. This is the same tool which is used in disease risk prediction across multiple disease pathologies. We also use this to study how a disease might reoccur in patients in post care. So it is used professionally, and we're using the same tool to predict dementia. This is outside of the screening itself. So we're doing preliminary screening. We are also predicting dementia, and this is what we uniquely like to sell ourselves in. We are an isotemporal based intervention quantification model. So what that means is we employ isotemporal substitution. Now, isotemporal substitution is a statistical model which basically takes in user data, and based on how the user is sort of behaving throughout the day, we can predict how the risk scores are increasing or decreasing. Now this helps us identify if certain treatments are working or if they're not working, and based on that we can suggest new treatment plans for that specific user. Now it is worth noting that dementia has no cure, and this is well established, but it is also worth noting that there's a lot of scope for offsetting dementia, and that is primarily what we are dealing with. So our isotemporal substitution model basically effectively states the specific set of activities the user has to do to have the lowest risk for dementia. So I think that is what our model is doing when it comes to the isotemporal section. We, as I've previously told, we have three subsystems. We are a screening model, we are a prediction model, we use Cox regression, and we also use isotemporal substitution to sort of model the intervention effect, to identify how well certain offsetting treatments are working on the patient and how well they're not. So this is what we are, and we have tied up with the Dementia India Alliance. We have a letter of understanding with them, through which we get a certain number of perks. We are getting essentially data from the Dementia India Alliance. They have promised us dementia care data. We are getting data from the UK bank. So all of our data is well established. We have now we specifically choosing data from the UK Biobank. This could be questionable. Why are we using the UK Biobank? Now, to clarify this, what I wanted to emphasize on is we are a compositional data model, which means we take data. So, what is a compositional data? When we talk about, for instance, let's say the time the user spends throughout the day, let's say the user spends like 30% of the day sleeping, and maybe another let's say 40% of the day just sitting down doing nothing and everything, and another 30% of the day doing exercise. So this data is essentially compositional data. So we take this data from the user, right? Once we have taken this data from the user, we then use our data from the UK Biobank, and what we do is we essentially compare the compositional data. Now, your biobank is one of the largest compositional data available, and usually it is also in consensus that regional cohorts for dementia do not are not distinct, which means the people who have or face dementia in India and specifically in that age group are not very different from, let's say, someone facing dementia in another country. The covariates aren't very they aren't sufficient enough to actually cause any imbalance between different cohorts and different people in different regions. So we are more than valid to take the data from the UK Biobank. It's also very large, it's very authentic, and we get the best compositional data which we need. Now, when we get this compositional data, what our isotemporal model is doing is it's measuring now between days. It's measuring now, for instance, if this is day one data, and let's say in day two, the user spends more amount of time actually exercising and lesser amount of time sitting down. So the fact that the user spend more amount of time exercising is substituted into the model, the isotemporal model, as we previously said, and that model throws out how much or how well that is affecting the risk score. And we do that in a more complex or multi, variate way, in that we take a lot of variables and we sort of calculate that, and we get a more customized treatment plan. We then try to evaluate different treatments and see which treatment is best working for our given user. So this is what I wanted to throw out. And what makes it special is we have associated ourselves with the Dementia India Alliance. It's one of the biggest dementia care centers in India. We have access to sort of promote the dementia centers and also kind of connect the patients, our patients, with the dementia center. So I think that is something very nice. As I've previously told, we are a screening model, we are a prediction model, we are an intervention effect subsystem model as well. And this is how it goes. The user enters the data is also used to kind of communicate with the Dementia India Alliance. Then we also have games. We have made cognitive boosting games. Now, we have done a research, and our research paper primarily states that if there's any cognitive boosting games, and even if the person is performing sedentary behavior where the person is simply sitting down and they aren't really doing any physical activities, even if that is the case, if they are mentally active during that period, we have noticed from our research that we can reduce the risk for dementia up to 50%. Now, the paper is attached, you can have a look at it. The stats are all verified and validated. So you're very welcome. But this is what we have concluded. We have concluded that cognitive stimulation is probably the single most important aspect when we're trying to reduce or prevent dementia, especially in those patients who are not able to physically move. There'll be a lot of physically disabled population, especially in the old age group. So I think what we wanted to do is we wanted to promote sort of these mentally stimulating games so they can readily stimulate themselves and sort of reduce the risk for dementia. We wanted to validate what we got theoretically in our research paper with this model, so that is also something we want to do. But once we have got this done, the user enters data, plays games, it's all in the front end, and then this goes to the back end, and then what is important here is we directly initially screen. We are using the factors mentioned in the landslip paper. It's a very popular paper for screening. We're using the same factors and we're sort of modifying a few things ourselves. But after the initial screening, we are checking for HR ratios, and if they're very positive, which means we notice that there's a higher risk, we then do two things. We first start measuring we start doing these substitutions throughout the day, and we see how the risk is decreasing or increasing. We sort of customize a treatment plan or an offset plan for the user. That is something we do. But at the same time, when the initial screening is done, we also send the data to the Cox regression model, which sort of predicts the risk for dementia for a more prolonged period of time. So there's a prolonged period of time. There's also, that's the prediction model, but we also have from the initial screening a basic hazard score of what could be if the person will have dementia or not. So that's like a very basic screening. We will also have this huge Cox regression model that states how the risk for dementia is throughout the entire time, if it's increasing, if it's going to decrease, and so on. And we also measure the isotemporal substitution throughout multiple days, and we see what treatment plan or offset plan is going to work and how it is helping or not helping the person. So we are basically doing a lot of things within the same platform. And at the same time, I'll also remind you that we are connecting with the dementia care centers. So if we believe that the person needs help, we will connect with them and we will make sure that the people who do need assistance are getting assistance through the DIA. Now, that is how we are working. There's a few things which we have also now. What we have understood is when we make such models, there is a very strong possibility of false negatives. And this is important. We don't want to falsely say a person does not have dementia, because that is bad, especially if you're diagnosing. You don't want to diagnose, you don't want to not diagnose something, right? You don't want to say someone is not having that disease. If you said someone has that disease and they get it verified, now that is okay. But if you say someone does not have that disease and they don't do anything about it, now that is a problem. And we realize that any of these fundamental health and fitness apps face this issue. So what we essentially do is we have a three-step course plan. We are reducing sensitivity of all our parameters, and we are basically diversifying our parameters. So reduce sensitivity and diverse the parameters, right? And what we're doing is we are adding a feedback loop. Now, if you notice that block diagram, you'll notice that there's a feedback loop, which takes data from the isotemporal model, and we are using AI to sort of set this control system, which basically goes back and forth and sort of improves the estimate of the data. What we are also doing is we are providing obviously two options for interfacing. There's an initial screening, and we're also doing prediction using Cox, right? So we're implementing these three plans to sort of get rid of this false negative narrative. But yes, we are also using this for validating our research paper data. We are also trying to use this to understand how dementia could be affected in long term, and we are connecting people with the dementia care centers. So I think that about ends it. I don't want to separately cover anything. I hope you had a good time listening to whatever we had to share to you, and we really hope to somehow make it and work on this model to actually see this happen. And this is a very feasible model. We have all the resources, we have all the support, and we hope to sort of progress with this and positively. Thank you.